Thank you so much. So this is a fun topic for me. I've spent the last decade or so working on combining these two fields, and hopefully in the next few minutes I can talk about why. So let's talk about the calcium algorithm. There are many of these, right? So you've seen them all. There's some look like the tube map from Paris, some from London, some look like the New York City subway, but they all sort of essentially say the same thing. And that is that we start with the angiogram because we have to identify the calcification, and then we should jump to intravascular imaging. So let's dive down on this step by step so we don't have to go through this in detail right now. This is the gatekeeper, right? The angiographic calcification. So we used to say that if you see calcification on one side of the vessel, it was moderate. If you saw calcium on both sides of the artery while it's moving, it's moderate to severe. And if you see calcium on both sides of the artery without it moving, it is severe. This is a core lab definition. It's completely antiquated because this is how we practice. The way we practice is if calcium's on one side, it's eccentric. If calcium's on both sides, it's moderate to severe. Interestingly, all of the data now confirms that you can dichotomize moderate to severe calcification and it has the same clinical outcomes. We did that recently for Illumian 4. Now, you can detect calcium in about 40% of the angiograms that you perform. And what we know is that if you have none, mild, or in this situation, moderate, not moderate to severe, moderate calcification, those patients do well. It really is the patients who have calcium on both sides of the artery that do the worst. And here you can see that patients with severe calcification on angiography are the ones who do the worst. They end up with stent under expansion. No question, the angiogram remains the gatekeeper. So we can do angiography-guided PCI, and that will never run away from the angiogram. But let's call this what it is. It's economy class, right? You can see as best as you can. You can identify concentric calcium, eccentric. You can clearly identify the uncrossable lesion, and that's about it. And what we're looking to do is get full non-compliant balloon expansion or a deformation of the nodule, and we have final angiography to determine our clinical outcome. But let's talk about business class. What do you get out of business class that's so much better than economy class? First, you get a morphology-guided lesion preparation. You know that if you've got a fibrotic or lipidic lesion, you really don't need to do any lesion preparation at all. Once you get to mild to moderate calcification or severe calcification, we need to start thinking about more advanced lesion preparation. And so, what is it that you actually gain from intravascular imaging? I told you you can see by angiography 40% of the time calcium, but you can see calcium by intravascular imaging 80% of the time. So does that matter? Is it just superfluous information or not? And so while the angiogram is the gatekeeper, what is missed by angiography? And what is missed by angiography is more than just the definition of severe calcium by imaging that you've been hearing, i.e. 270 degrees or 180 degrees. That is, again, a core lab definition and never should have been adopted. What we did over the last 5 years is identify the predictors of stent under expansion by intravascular imaging. This is IVUS. If you have circumferential calcium, if you have an arc greater than 270 with a length greater than 5 millimeters, if you have a calcified nodule, or if your vessel is small because of Laplace's law, these are all predictors for stent under expansion by IVUS. We did the same thing for OCT. This is the rule of threes. You remember the rule of fives that we did with 50% of the arc. This is updated for only patients with severe angiographic calcification. So this answers the question I mentioned before. This is angiographically severe calcification. Within the angiographically severe calcified group, if you have a maximum calcium angle of 360 degrees, if your calcium is 0.3 millimeters thick at its thinnest point, and if you have 270 degrees of arc that's greater than 3 millimeters, these all predict stent under expansion. So what does that mean? Intravascular imaging allows you to determine not only the presence or absence of calcium, but it will help you build on what you get from angiography. More so, you can determine what is the phenotype of the calcium, concentric, eccentric, nodular, or deep, and all of these have different clinical outcomes. What are we looking for? We're looking to get full non-compliant balloon expansion or calcium fracture. What does that look like? This is a typical pattern of IVUS calcium fracture. You can see sound actually going through the space of these calcified plates, which is actually creating a reverberation. And on OCT, you don't really have to be a rocket scientist to be able to see a calcium fracture. It's really very easy. Now let's go back to the algorithm. Deep calcium. What is deep calcium? There is no such thing as deep calcium in the coronary artery, which creates stent underexpansion. The only type of calcium there is thick cap or thin cap. Mockenberg's calcific arteriosclerosis, which happens in the media, doesn't impact stent expansion. So what you want to know is there a pillow on top of your glass or plate? Simple as that. When this gets to more than 0.5 millimeters thick, it impacts your stent expansion and your ability to use technology. The only things that work with thick cap calcification is IVL or laser. Why doesn't atherectomy work? Because when you put a pillow on top of a glass or a drill on top of this, the drill will basically destroy your soft tissue. It cannot penetrate the calcium that's eccentric underneath a thick plaque. What works? Intravascular lithotripsy, especially if you squeeze the pillow. This is very important. If you use an undersized balloon with intravascular lithotripsy, you'll basically be putting your sledgehammer into a pillow. It does nothing. Laser also is highly effective in these situations. Laser creates a cavitation bubble identical to intravascular lithotripsy, unfortunately without the balloon that creates the safety, right? The laser creates the energy in the blood or with saline, and there's no balloon to protect from the vapor bubble going down. Now, fortunately, superficial calcium is the vast majority of what we see. And I'll be the first to say, despite my conflict with Shockwave, that everything works. Atherectomy works, laser works, IVL works. So let's take a look why. Because the calcium is abutting the lumen. So anything that will touch the wall will be able to modify it. Atherectomy, cutting balloon, non-compliant balloon, and intravascular lithotripsy. So how do you decide? Well, one is to determine whether you have superficial eccentric or concentric calcium. If you have concentric calcium and you have contact between your intravascular imaging catheter, it will do what it says on the box. It will thin this calcium down, and then you'll be able to break it. And so look at this example of where you have favorable wire bias. You thin this calcium down to a point at which it can be fractured, it's broken, and you get a very large minimal stent area. Where don't you want to use atherectomy? When you have severe wire bias. When you have severe wire bias, you can end up cutting into the normal part of the artery, and this is where the risk is introduced. Now, the advantage of intravascular lithotripsy is it doesn't know which side the calcium's on, nor does it really care. If the calcium is there, it will deliver energy into that segment and create a fracture. And so what intravascular lithotripsy does is indiscriminately circumferentially deliver energy. If there's calcium on that side, it will break it. And we showed multiple times now in over a dozen publications that the mechanism by which IVL works is by fracturing calcium. What about the randomized data? This is the latest, EuroPCR 2 years ago, published this year, a randomized controlled trial of rotational IVL and laser. Full disclosure, I said before, they all work for efficacy. But what is the discriminator? Safety. Zero safety events with intravascular lithotripsy. So if everything works, what is your discriminator? It's going to be evidence that you have the least number of complications. If you look in this 561 patients from all the disrupt CAD patients, 0 perforations with intravascular lithotripsy, 0 abrupt closures, 1 slow flow, and 1 no reflow. We've updated this meta-analysis to over 1,200 perforations, 0 perforations after intravascular lithotripsy. What about nodular calcium or eccentric calcium? Well, first of all, a calcified nodule, we know what this looks like now. We know that these are big problems. No, eccentric calcium is a big problem. Why is this challenging? The reason it's challenging is because when you inflate a balloon on eccentric or nodular calcium, you get a very eccentric balloon expansion. And here's a perfect example, right? We inflate a balloon, you have this big boulder underneath, it's not really moving. And so what we tend to do, and we saw this in the previous speaker, is use atherectomy. However, the data for the atherectomy is very poor. And what actually happens is most of the time when we have eccentric or nodular calcium, this is simple physics, like your child's top. If you spin a top and it hits something hard and it's spaced to ricochet, it will always take the path of least resistance. So the amount of debulking that happens with atherectomy is extremely small. Look at this. after atherectomy, only 0.17 millimeters of gain. This is inadequate vessel preparation, and the reason that happens is most of the time the bias of the wire favors away from the nodule. And so what we think happens is this, but what actually happens is this, like cutting the top of a Himalayan mountain off. So beware, and not to mention that, the event rate in patients treated with rotational atherectomy and calcified nodules is very bad. And the reason is we probably think we are debulking a lot of the plaque. The reality is you're debulking approximately 11% of the plaque. Now, what do we have? We have intravascular lithotripsy. What is the evidence for intravascular lithotripsy being able to work? Not only is there cadaver experiment data, which shows in this basically uneventful OCT, which actually looks worse to me, but if you see intravascular lithotripsy delivers energy into the nodule and fractures it on micro-CT into multiple pieces. When you crack your rock into marbles and pebbles, you can push them away much more easily because of the compliance. And look at this very eccentric calcification, which is broken over time by delivering more shocks to the point at which you can get full expansion. We showed that patients with or without a calcified nodule have a similar clinical outcome. This is the only data to show that any device can create a level playing field for calcified nodules. We also showed exactly the same thing for IVL and eccentric lesions, showing that IVL will fracture calcium irrespective of whether it's circumferential or not. This is the latest and greatest for uncrossable lesions, which has traditionally been only for rotational atherectomy. First of all, for those of you who haven't seen this, the Aero device, which is the new IVL catheter, is absolutely phenomenal. This deliverability issue is gone. And for those of you who haven't seen Javelin, this is the first case. This is the Javelin in this extremely tortuous, heavily calcified LAD, where the Javelin tracks right through. This is a microcatheter with an emitter at its tip that tracks right through the artery. No risk for cutting the artery open, a game changer for interventional cardiology. So that's the latest and greatest of what's coming up for intravascular imaging guided PCI in calcified lesions. Thank you very much for your attention.